Whoever thought making a baby could be so hard? Luckily, the fertility journey isn't meant to be traveled alone. Eloise Drain has helped hundreds of people build and grow their families over the last 15 years, and she's ready to share her insider knowledge and expertise with you. So grab a seat and let's talk fertility and alternative family building in the Fertility Café.
When it comes to third party, there are so many unknowns. So today, I'm excited to speak to our guest, Dr. Lori Marshall. Dr. Marshall is the medical director and a founding partner of Pacific Northwest Fertility in Seattle, as well as clinical professor of obstetrics and gynecology at University of Washington School of Medicine. She serves as the director of the Pacific Northwest Fertility Center for Collaborative Reproduction, overseeing its donor egg bank and donor egg, gestational carrier, and donor embryo programs. She received her bachelor's and medical degree through the honors program at Northwestern Medical School, did her residency in OBGYN at UC San Diego, and her fellowship in reproductive endocrinology and infertility at UCSF. Dr. Marshall is board certified in both obstetrics and gynecology and reproductive endocrinology and infertility. After serving on the faculty at UCSF, she moved to Seattle, initiated and led for 18 years an IVF center at Virginia Mason Medical Center, and then founded Pacific Northwest Fertility in 2005. Well, thank you, Dr. Marshall. Thank you so much for joining me and welcome. So I was rather impressed with reading your bio, but I would love for you to share a bit about yourself to the audience.
Okay, so I'm one of the old folks in our field, and I tell people that I've had a wonderful career because it has spanned basically the history of a really important medical discovery, progress, innovation, which is in vitro fertilization. I was in medical school when Louise Brown was born. Wow. And so I have been able to participate and observe many of the developments in our field. And it has made it, for me, a deeply satisfying field. I originally was interested in neuroendocrinology and did my residency at UCSD with Sam Yen, who is obsessed with that topic. But over time, I've been interested in all sorts of different things in our field. Probably about 20 years ago, I started to be more interested in the reproductive ethics and sat for quite a while on the ethics committee of ASRM and as well as the ethics committee of the American College of OBGYN. And through those relationships, I've become much more interested in the complexities of reproduction. And one of those very complex aspects is the involvement of other individuals in reproduction, which I like to refer to as collaborative reproduction and others call third-party reproduction. So, I have been doing donor egg cycles since the 1990s. And with the first cycles that I did were on a friend of one of my patients who volunteered to be an egg donor. And over time, I became more and more interested in donor egg as a service that we provided. I've had the privilege of meeting one of the first egg donors in the world. One of the first papers on egg donation reported on egg donors from Israel. And I ultimately took care of one of those women and helped her get pregnant with in vitro fertilization when she was 39 years old. So I've been very interested in this field. And we do have sort of a medium-sized IVF program in Seattle, but we have done more egg donation, I think, than most programs do because of our proximity to Canada.
Yes.
And Canada, first British Columbia and then Canada, paid egg donation has been illegal for many years. And therefore, many of those patients came to Seattle for their egg donor cycles. So there have been times when half of our egg donor program were Canadian patients. So we've often done more egg donation than most other programs. We have always done it without working with an agency. So we have been our own agency for the most part. We have recruited and screened donors ourselves, and so have kept our thumb on all aspects of patient care, both care of the donor and care of the recipient. And that has been a very highly satisfying way to provide donor egg services.
And I absolutely love, obviously, I follow Pacific Northwest Fertility, and then I follow your other colleagues, and love your donor program, specifically because I know that you guys care very much for your donors. Being a donor myself, starting in 1999. So, kind of going back, one of the older people too, right? Yes. And seeing the drastic change, because Lord only knows, when I was considering being a donor, there wasn't really a lot of information out there like there is right now. And so you didn't really know what to expect. You didn't really know what to know. What is it going to be like, and how is it going to be? And even still right now, though, I still think that there's a lot of women, if they were educated enough to really understand the donor process, that potentially there could be more women that would be willing to step up and become donors.
Yeah, an awful lot of the donors that we care for in our program are referred by their friends.
Yeah.
So there's a lot of word of mouth referrals, and we do pride ourselves in how well we take care of the donors. In the old days, when it was just fresh donor egg cycles, the recipients used to write letters and give gifts to the donors, and they still do when we do fresh donor egg cycles. But now more and more, some of our donors are just doing cycles to put eggs in our egg bank, which we've had since 2009, in fact. And so we don't have that extra recipient sort of thanking them and personalizing it. So we as a program do that. So we write them a letter. We every single member of the team signs it. We often have a personalized note like "Good luck with your schooling" or "Good luck with this." And so we do want the donors to feel like they're doing something really special. And just the money isn't enough.
That's right.
And the donors that feel like they're doing something good for other women are the ones who are the easiest for us to work with. They're the most satisfied with the procedure, and they come back for other procedures. And so we do think that it is important to keep that personal touch and to make the donor feel valuable in the process.
Yeah, I definitely agree. And I actually wanted to specifically speak about your practice, because I think that you were co-founded, but I think that you lead a very unique practice that is an all-led female medical staff, which is highly unusual. I think if I think about it, maybe one or two other practices in the whole country are all female-led staff. So was that intentional when you developed this practice, or did it just happen, or?
It just happened. The co-founder of the practice was Lee Hickok, who is male. And so we did have a male partner for many, many years. He retired about 5 years ago. And it really has not been intentional that we have all women, but most folks in the field know that more and more women are going into obstetrics and gynecology, and therefore more and more women are going into the subspecialties. And it really has just been that we look for the right person at the right time, and it just happened to be female. So we now have 5 female physicians. Not all of our staff are female. One of our director of our embryology lab is male. So
got it.
So we do it's not deliberate, but patients are comforted, I think by knowing that if they see a provider, that it's going to be female.
Yeah. And I think, and I can only speak for myself as a woman, that I also do prefer my physicians to be women. It's just when I share something that I'm experiencing or going through, oftentimes they know exactly what I'm experiencing and they can empathize because they perhaps have experienced the same thing.
Right.
Yeah.
Yes, some women like to tell their stories and some don't, right?
Sure.
But I think that many women who are in the field do have their own stories that they could tell, and at least they can incorporate them into the experience as they care for their patients.
Yeah, I definitely agree. You stated on a video on your website that your practice has intentionally limited its size and you're not trying to be the largest practice in the Northwest, and that you want to provide a more intimate care experience, which I can certainly relate. As our agency, although we're considered mid-size, we very much prioritize personalized service as well. And I wanted to ask you, number one, again, was that intentional about the size of the practice? And what do you think the benefits are for your patients when you do it, when you've set it up that way?
Right. We struggle with this all the time. And because there is a huge demand in the Seattle area for fertility services, and we hate for people to wait to come into the practice. But we do think that ultimately the practice runs in a more intimate way if we can keep the size down. We initially said no more than 4 physicians. We have 5 now. And we did open a satellite in one of the suburbs, Bellevue, just outside of Seattle. But we are very deliberate about our choices for growth. I've always said I don't want to be in a position where one of my patients gets pregnant and I don't know who she is.
Yeah.
Right. I never wanted be in that position. I think the satisfaction for all the providers and the team are greater if we can have a more intimate experience. And that's transmitted to the patients. Many of the patients who come say, I can just tell that people here like their job. And that's important to us, to keep our staff, to have them happy. And that translates into better care, I think, of our patients.
Yeah, I definitely agree. So I wanted to ask, as you had already alluded to this, that you sat on the ethics committee of ASRM and ACOG for many years, and you're a leader in medical and ethical issues in egg donation and speak and write frequently on the topic. What do you feel is the third-party reproduction ethical considerations of our time now? I mean, there's super donors, anonymity, informed consent, long-term effects of egg donation. I know, hence
there's so many. Yes, I mean, I could list 15, 20, right? There's lots of them. I mean, I do think one of the biggest ones is how commercialized and commodified the process has become.
Yes.
And to sort of broker that, because you want the donors to be autonomous and to have their choices. And, if you want them to be able to bargain for the amount of money that they get. But on the other hand, this is a medical process. And we consider things like informed consent very important. And part of informed consent is not being coerced to do something, to take risks that you don't need to take. And so we're always considering these issues: compensation to donors, sort of separating the relationships that are involved in collaborative reproduction from sort of frank commercialism, and trying to keep this from being just a financial transaction. So I think that's one of the challenging ones. And that undercurrent does affect an awful lot of things that we do. I think the other issue, I think you mentioned disclosure, which is a fascinating one. In the early days of egg donation, there sort of used to be 2 models. One was, we used to call it the California model, and the other was the Pacific Northwest model, right? So the California model was the model where the donor would meet the recipient couple and say, I'm going to give you my eggs. And she would do a fresh donor cycle, and all those eggs would go to the recipient couple. And most folks that we cared for in the Pacific Northwest and in Canada preferred anonymity.
Mm-hmm.
And they wanted to have a child. Many of them probably didn't disclose the circumstances of their conception to their offspring and had no intention to. And really, with not that many people knowing about donor egg as an offering, they raised their children with them not really knowing that they were conceived with donor egg.
So speaking of anonymity and the big place where anonymity is huge, obviously in frozen egg bank programs, but we also know that there's tests like DNA and what is it? DNA and Me or 23andMe. There you go. Yes.
Right,
yeah.
Mm-hmm.
How do you think that is going to fare with now all of these organizations that are coming up, and even with your practice, how are you all, trying to think long term about donor anonymity?
Well, actually, we've eliminated the term anonymous from describing donor egg cycles. And so both unofficially and officially, we now say you have either a directed or a non-directed donor.
Got it.
So a directed donor cycle would be what we used to say is a known donor cycle. So a sister or somebody that you know who is giving their eggs specifically for a person that they know, right? And a non-directed donor would be what we used to call anonymous, right? Which basically would be the eggs that are in the bank. Those women who gave their eggs to put in the bank are not directing their eggs toward anyone individually. But we've actually dropped the term anonymous from all of our paperwork and our consents so that people don't believe that it's going to be anonymous.
That's a great idea.
You need to enter into this process knowing it's not anonymous. And we talk to them about at-home ancestry testing, and your kid can buy these kits and find out that they have siblings that are out there somewhere, or relatives that really weren't part of what they believe to be their nuclear family, and raise questions. And so the best thing is just to start from the beginning and make donor egg part of your child's story. And in different ways. And there's so many people who are thinking about this now in children's books and such that I think it's going to be the standard that children grow up knowing the circumstances of their conception. In Washington State, there is a law that requires, since 2011, there has been a law that requires that any man or woman any person who gives eggs or sperm at the time of donation basically agrees to saying that when the child turns 18, that child can know the name and the birth date of their sperm or egg donor.
That's a law.
It's a law. And
wow.
the donor can be accepted from it. So they can, at the time of donation, they can say, no, I don't want to agree to being an open identity donor. So this is what's called an open identity donor in Washington State. It's not that the child, when they're 5, can know who the donor is. When the child turns 18, they can have that information. The law has actually been with the Uniform Parentage Act that was recently passed and became effective in the beginning of 2019. They can be asked twice for that permission. So at the time of donation, unless they sign the affidavit saying, I don't want to do this, then that child can be given that information by the program. But if the donor didn't agree to it at the time of donation, we're now required to try to reach out to the donor and ask them again.
Wow.
When the child turns 18. So I believe that we're the only state that this is part of the law. And, but it is one step toward respecting the offspring. So what we always say in a donor egg relationship is that the donor signs the consent, the recipient couple signs the consent, but the child doesn't consent to the relationship. So,
that's right.
So when the child reaches an age when they can process this information and they can be independent, then most people feel that they do have a right to know who the donor is if they choose to know that.
Yeah, as a matter of fact, I did a podcast, and off the top of my head, I can't remember what episode it was, but it was Erin Jackson, who was the founder of Donor Conceived. We are Donor Conceived. And I mean, in the conversation, there was so many eye-opening things that she shared with me about the children that are, the product, if you will, for lack of better terms, of the results of, the parents wanting children and, making or having to make these decisions about, having to use donor eggs or even working with a gestational carrier or whatever the case might be. And how that affects their life long term when, and I think we also as a society, in industry, I should say, in the professional community, that we need to step up and start discussing and having these conversations with these families and making it that it's okay. It's okay to work with a donor. It's okay for that to be your story. It's okay for it to be your child's story instead of being so embarrassed or ashamed or wanted to be hidden because you don't want anybody to know or, whatever the case might be, because I'm sure you're probably not going to love your child any less.
Of course not. Right. Those are obviously very wanted children.
Of course.
I think the hard thing is that most women, when they come to deciding to use an egg donor to have a child, they're pretty beat up at that point.
Of course.
Right. And so they are not very secure in their motherhood. And, and then they get pregnant, they carry the pregnancy, they deliver the child, they breastfeed the child. In their mind, there's no way that anyone else has a claim on this child to be their mother, right? And so it's the easiest thing not to tell the child. And of course, as with all pieces of important information, there's never a good time to do it. So even folks that intend to often don't know how to, and every child's different. I think it's hard for a child to be raised in this society and you throw one more thing at them, and that's difficult. So I think you're right that that so many people have the preconception that if they have a child with donor egg, they're not the biological parent. And of course they are the biological parent. By just carrying the pregnancy, delivering the child, they are the gestational mother of the child. They're just not the genetic mother. And we are learning more and more about epigenetics, how actually the environment that the child's exposed to in utero affects the expression of genes. For each gene, there's either a maternal or a paternal one that's turned on, and that's affected by the environment. So your environment that you provide for the child has a lot to do with even their, how their DNA is used, basically. Still, the strand is, from the donor. There's no question about that. But still, you do have a genetic influence on your child as the gestational parent. So I think people just have to use the right language. And I always talk to my patients about it. I said, people, if you tell them that you had a child with donor egg, they're going to say, well, how does it feel not being the real mother of the child? And I said, of course, you're the real mother. You are the real and the only mother of the child and a biological mother of the child. And the woman who's the donor doesn't want to be the mother of your child.
No.
And you are the only person who can be and wants to be the mother of your child. It's difficult. And I would have hoped that the community would be more accepting now than they are. But I still think there's a long ways to go.
Oh, yes.
As I talk to patients and how hard it is for older women who have low egg supplies to embrace moving to donor egg. All I can say is that women who have done it are like, why didn't I do this before? Why did I put myself through everything I put myself through when this is the way I could have built my family? And it's so highly satisfying.
And with all the heartache and pain and grief that you would have saved yourself from experiencing all of those other years of attempting. So I actually want to jump into the conversation about gestational carriers because I obviously have been a gestational carrier myself, and in your perspective of the gestational carrier still having some kind of connection with this child's overall life, I mean, I find that fascinating, and I definitely want to discuss that a little bit more. And just really trying to understand for somebody who obviously wants to be a gestational carrier, and then even for the intended parents, like, oh my God, no, I don't want to work with a GC because now my child is going to be genetically related. Can we discuss that, thought a bit more?
So are you saying that because of epigenetics and because of the influence
yes,
of the
yes.
Yeah, I mean, I think that's part of it, but I still think that couples that develop embryos and then a carrier carries the pregnancy that has the woman's, the female partner's eggs and the male partner's sperm. There's no question that who the parents are. But I do think actually that having a child with egg donor is easier than maybe having a child through a carrier, that it is maybe harder to feel confident that you're the parent of this child. Genetics help a little bit, but they don't help completely. These are all challenges of adulthood. Yes. Is anytime you move into collaborative reproduction, it is a challenge. So I think that's where all the safeguards that we try to put in place for carrier cycles are important. So legal contracts, I tell people the legal contract is, don't be scared of that. That's a way that you can look through all the possible things that can happen. Think about them ahead of time, address them ahead of time, and come out of this with a good relationship with your carrier and a good relationship with your family, their family, and feel like this is a healthy relationship. So counseling and legal contracts are so important. And legal contracts that the carrier has a different lawyer than the couple. I mean, I've seen, part of the problem with carrier cycles, and I'm sure you see this, is that it's gotten so expensive.
Oh my gosh, it's crazy.
That it's unreachable for most folks. And so there's more and more people who are trying to do DIY carrier cycles. And that's a huge can of worms, because that's really the time when you're sort of set up to have difficulties and the carrier being too much in your child's life.
Yes. I wholeheartedly agree. When I started my surrogacy journey to today, and the cost and the drastic change in cost for surrogacy. And I mean, going back to the point you had actually discussed about it now becoming more of a business transaction rather than an emotional connection with the families that you're carrying for, or even being a donor for. On the surrogacy side, it has absolutely become a business transaction, which is a bit scary. Quite honestly, that it has become so more business than the emotional side, because unfortunately now there's a lot more families that can't afford it. And then there's a lot more surrogates that think they can be, or potential surrogates, I should say, or potential gestational carriers. I know in the medical term it's gestational carriers, but lay people typically say surrogates.
Sure.
And that there are unfortunately some surrogates that think like, oh no, look at all the money that I can make. And so, it doesn't matter what the consequences are or what I have to go through. I'm going to do it because of the amount of money that's there, which goes back to the point that there's different organizations that talk about when you work with a gestational surrogate or gestational carrier or surrogate, or that we're exploiting women and we're taking advantage of women because, there's all this money that's being thrown at them, but they don't really understand the process that these women have to go through in order to even be approved to be a gestational carrier.
Right.
And I know that GCs must meet ASRM guidelines, clinic standards. And if they're working with an agency standards, Were you involved in the creation of the current ASRM guidelines for surrogates? Can you tell us a bit about how
No,
okay,
no, I wasn't. I rotated off the ethics committee
by that point?
by that point.
Yeah.
Yes.
But
Yeah.
can you speak on why the importance of screening these candidates where, medical records and psychological
Absolutely.
evaluations and the attorneys, like you were saying, and making sure that everybody has separate legal counsel so that they each feel that they're being represented. And and then even of course, the medical screening and all of that, of what that entails.
Right.
Can you touch on that a bit?
Right. I think that just as with egg donor services, with carrier services, even when there are agencies involved, that physicians really are, the professionals that are the helm of this. And our first obligation is to make sure that our patients stay safe, that they come out of this healthy, and that the babies have the best chance to be healthy as well. So that's the first thing that we have in mind. And so we do deal with in Washington State that we do have separate laws about surrogacy that are just a teeny bit different than our guidelines. Like, for example, Washington State, the carrier has to have had a child, and in order to be a surrogate. And ASRM has an upper limit of age 44. We don't want women who are 49 years old to be carrying a pregnancy, because we think 45 years old is a time when the risk to the woman starts to go up. More women have diabetes, et cetera. And we really want the carriers to take this seriously. I think the riskiest thing a woman does in her life almost is to be pregnant. And I think, unfortunately, we've recently become aware of risks to a carrier, to their health and even to their life. They can have things like an ectopic pregnancy. They can have a miscarriage and bleed. They can bleed at the time of delivery and lose their uterus. So it's certainly best that carriers have completed their childbearing at the time that they decide to be a carrier. And then in terms of health, that's always a judgment call. And usually the surrogate agencies have done some pre-screening of the carriers because they don't want to invest too much time and money into them if they're not going to be a good candidate. But we always review their obstetrical records and make sure that there have not been complications of prior pregnancies that we could expect will occur in another pregnancy. So that's for the protection of both the carrier and the recipient couple. So, and if a carrier has had preterm labor, they probably got a higher chance of having it again. And that adds expense to the process. And anything that adds expense to a carrier cycle is not in the interest of the intended parents. And so we try to look out for both parties in this process. But we also know how much money the intended parents are paying for these cycles. And we really don't want them to spend money and have complications of the pregnancy or complications to the child.
Yes, definitely. And strangely, there is still a lot of confusion about how surrogates become pregnant. And I know with this, many because partners of would-be surrogates are initially against them becoming surrogates until they're clear on how the pregnancy is achieved via a medical process. And as a matter of fact, when I first decided to become a surrogate, I can't even remember where I was, and the lady congratulated me, and I was like, no, it's a surrogacy pregnancy. She's like, oh my God, your husband let you sleep with another man? I was like, no.
Well,
that is not how it works.
Right?
Yes.
Right?
Yes.
So, science fiction literature influences how we perceive these things, right?
Yes.
So, yeah.
Can you describe the medical process of an embryo transfer into a gestational carrier. And the gestational carrier is not sleeping with anybody? So,
absolutely not. Absolutely not. So there used to be, we used to say, there's traditional surrogacy.
That's right.
Versus gestational surrogacy, right? So with traditional surrogacy, meaning that the egg of the carrier was used for to achieve the pregnancy.
Mm-hmm.
And in that case, you can imagine that it was sex. It usually isn't. It usually would be something like insemination of the husband, who is the intended parent, into the carrier. And then the carrier would become pregnant and deliver the child. So she has two biological connections to the child. So she carries the pregnancy, but she also provides the egg, right? So that gives her two claims of motherhood, and the conflict that has arisen from that was the reason why in Washington State for many years paid surrogacy was against the law.
Yeah.
Right? The Whitehead case many years ago was a traditional surrogacy relationship, and that's why in most states that's not allowed. And in our field, we don't participate in those. We only participate in what we call gestational surrogacy, where the egg is not from the carrier. The egg is either from a donor or from the intended parent, female parent. So that is what we do, and that's what we refer to as gestational surrogacy or a gestational carrier. Interestingly, and you probably know this, in the state of Washington, when they passed the Uniform Parentage Act in 2019, that they do allow traditional surrogacy.
Really?
Yes, it is allowed by law, but the stipulations are so strict that you would never do it. So you have to, in order to establish a pregnancy in that manner, which generally would be insemination of the husband's sperm into the carrier, you have to first go before a court and get special court permission to do it. And then there's a contract that's drawn up, but the carrier can change their mind up into a certain time after delivery and decide she wants to keep the child. And if she does that, then the intended parents are still responsible for all of her care, right? So it's sort of ridiculous that in there, but it's there, and so it's not illegal. I think the concern when this was decided upon is that to say it was illegal would have raised too many objections. And so instead they say it's legal, but there's so many hoops that you have to jump through that it's not a practical option.
Yeah. And I mean, and we don't do any. Yes, that's very fascinating. And I had no idea. I mean, I did read the Uniform Act, but I did not. And probably because, again, we don't do any traditional surrogacy either.
Neither do we. Right.
And so I don't really put my focus, to be honest, in traditional surrogacy. So, but these are the reasons why, I mean, I don't know any intended parent in their right mind that would say, oh yeah, not a problem. I can try that and let's just see what happens.
Right.
No,
right.
I personally would never agree to that. That's for sure. Well, I want to know when it comes to the actual embryo transfer with the gestational carriers, oftentimes we get the question like, oh my God, is it painful? Is it going to hurt? Or, and I can tell you, I've done it many times, a total of 7 to be exact.
Wow.
Yes. So I can tell you it's definitely not painful. Obviously the worst part is that full bladder, but can you kind of share from a medical perspective on the process and the experience?
Sure. So it's just like any embryo transfer we do for IVF, for egg donor, is same for carrier cycle. And basically, we do have women usually drink water and fill their bladder. And Eloise was correct that usually that's the hardest part of the procedure. And usually it goes very smoothly, particularly carriers have had children before, and it's usually easier to put a catheter through the cervix when it's been dilated and there's been a vaginal birth. So we put in a speculum, just sort of flush off the cervix, put a little catheter gently into just the very lower portion of the uterus, and then the embryologist loads the embryo, and we thread it through the outer sheath of the catheter into the uterus and inject it. And really, truly, the full bladder and putting a speculum in the vagina when your bladder's full is the hardest part of it.
Right. Yeah.
We try to, make the experience good for the carrier too. We have a video feed from the microscope to a little screen that's in the room. So the carrier can see the embryo and can watch the embryologist draw the embryo up into a catheter, which is just fun and interesting. And then during COVID, they can FaceTime whoever they wanted to the room. Haven't allowed intended parents to be in the room during COVID.
Yeah.
But at other times, we do allow intended parents to be in the room and are just very discreet about that, right?
Of course.
So obviously, it's a vaginal procedure. And we allow, if they want their own partner to be in the room, that's fine too, because sometimes they feel more supported by their own partner than by the intended parents, where they have this sort of personal, transactional relationship with, right? We take care of them just like we take care of any patients. And I think the most important thing, being at the helm of a collaborative reproduction program, is that our intended parents are our patients, but also our donors are our patients and our carriers are our patients. And we value them as much as we do the intended parents.
Yeah, which I wish everybody could do the same thing. We definitely do the same through our agency. I typically say it's kind of like a triangle, the GCs and the donors on one side, the intended parents on the other side. And there's this peak at the top that this child that we are all collectively, working to bring to fruition. And it could be one of the most amazing, beautiful experiences you can be a part of.
So, and we want to keep it that way.
Yes. Yeah. Yes. Mm-hmm. I wholeheartedly agree. Excuse me. So any words of advice that you would share with our listeners when it comes to, I love how you guys say it, collaborative reproduction instead of third-party reproduction, since that is what this podcast is really focused on. Any words of advice?
I think for intended parents, I think you just have to treasure any part of your contact with the program, the donor, or the carrier that humanizes the donor and the carrier. That you really still, even though you want to sort of put that donor in the back of your mind, I think it's better to know a little bit about the donor, to recognize they're human. It's the first step in recognizing your child's human too, right? So you are not purchasing a perfect product, and you can't expect that. And these donors are doing this. Yes, they get money for it, but most of the time, donors, the money's not enough to do this, right? And they are doing it for you too, and so that you can build your family. And so I think to keep that in mind and to keep sort of their feelings and what they've had to go through to donate their eggs in mind is really important. I think it's also important for if you have a carrier and you're an intended parent, is to recognize that being a carrier is the riskiest thing a woman does, and that again, they are getting well compensated for it, but they really are taking a big risk. And that you do need to appreciate that. And so any couples that are considering using a carrier need to take it seriously. It can't be, oh, darn, I really don't want to have those stretch marks and I'll just get one of those carriers, right? So it really there has to be a good reason to have a carrier. It has to be a medical issue, or you can't get pregnant any other way. And it is a last resort, and the price that it costs means that it does become your last resort, of course.
Yes.
And I think for donors and carriers, I think it's important for you to know that even when it does feel like a transaction, that really that the couples that build their families will look back at what you did so fondly.
And eventually too, that, you can look back even within yourself and give yourself the credit that you truly have helped. You helped build a another legacy for somebody else.
Right. And it's good to remember that the money will go away and
That's
we'll,
right.
buy some furniture or be
That's right.
down payment on a house or something like that. But really what you've done for this couple is what lasts.
That's right. For a long time. And who knows how many generations later,
Yeah.
So thank you so much, Dr. Marshall, for joining me today. How can our listeners find you?
Well, Pacific Northwest Fertility is our clinic. Yeah. And we are what is it? PNWfertility.com is our website. And that's how you can find me. I am not big into social media. So I do have an Instagram, Dr. Lori Marshall, but I otherwise don't participate in social media except through our practice.
Likewise. So I try, but I just have no interest for some reason. So, regardless, we will make sure that all of your information is in our show notes. And I just really want to take the time to thank you. Thank you for taking the time out of your busy schedule to talk to us and to help us to learn more and educate our listeners. And I really appreciate your time.
And thank you so much for inviting me. That was a delight to chat with you.
Absolutely. Thank you so much. I hope you found this discussion helpful as you weigh your next steps. You can follow Fertility Café on its Instagram and Facebook channel, Family Inceptions. If you haven't yet, go to your listening platform of choice and subscribe, rate, and review this podcast. We'd also love you to share Fertility Café with friends and family members who would benefit from the information shared. Thank you so much for joining me today. Remember, love has no limits. Neither should parenthood.
Thank you for joining us in the Fertility Café. Whether you're an intended parent, a woman considering egg donation, thinking of becoming a surrogate yourself, or a friend or family member of someone dealing with infertility, we're here to help. Visit our website, thefertilitycafe.com, for resources on fertility, alternative family building, and making this journey your own.